thank you for joining us this afternoon for our monthly Community Mental Health Transformation webinar. I'm Megan G, the Communications Manager supporting the programme, and today we are joined by our colleagues in the Community Rehabilitation Pathway to speak about the work that's been happening, lots of exciting developments there, and Dr. Emily Gray and Stina Bormann are going to be leading our presentations today, but we're also joined by Becky, Laura and Nicola, who are also going to share some of the local work that's been happening as well. We're just going to start off with a little bit of housekeeping just to make sure that we're all settled and know kind of what to expect of this afternoon. So if you would like to turn on live captions for the session today, you can do so by clicking on the dots in the bottom right hand corner of your screen, and you can turn on live captions if that is helpful for you today. This is going to be approximately 30 minutes of presentations, and then there'll be 15 minutes at the end for Q&A. So do feel free to pop in any questions that you think of throughout the duration of the webinar. You can either use the Q&A box at the bottom, or there is also the chat box. I'll be keeping an eye on both of those throughout, so do feel free to use whichever feels best. Because this is a live webinar, which we are recording, just wanted to make people aware that the recording of this webinar does get published on our Community Transformation YouTube playlist. So if you would prefer to keep your camera off or to anonymise your name, that's absolutely fine. Please feel free to do so. But equally, obviously, you are very encouraged to keep your camera on and to participate with us this afternoon. A summary of the topic covered today and a copy of the slides will be circulated around to everyone who's registered for the webinar. So if you do have colleagues or family, friends who are interested in this work, do feel free to obviously share that with them, as well as the link to the recording to be able to watch the webinar back if they are unable to tune in live this afternoon. And lastly, we also have a very short survey that we send round. So if you have the opportunity, if you're able to fill that in, it just really helps us just to check that the webinars are still useful for the people attending. And it also gives you the opportunity to suggest any future topics or presenters that you might like to see included in our schedule of webinars. So yeah, do please send that through if you can. And then just a reminder that obviously we do record all of our webinars, and we've got quite a selection of them available now. So if you scan the QR code that's on the screen at the moment, it will take you to the YouTube playlist, but I'll also share the link in the email that I send round later on. So you can watch those back if you haven't already. So that's it from me in terms of the housekeeping. I'm now going to hand over to Stina and Emily, who are going to get us started in our presentation this afternoon. Thank you.
Thanks very much, Megan. Welcome everybody. Thanks for coming today. So my name's Emily Gray. I'm consultant clinical psychologist with the SAM team. That's the Specialist Assessment MDT within Sussex Partnership Trust. I'm also a co-chair of the Rehab Steering Group as part of Community Transformation. And I'll just hand you over to Stina to introduce herself.
Thank you, Emily. Hi all, I'm Stina Bormann. I head up the West Sussex Mental Health Commissioning team, and I co-chair the Community Rehabilitation Steering Group. Shall I just very quickly run through the agenda, and we can introduce our other presenters. So as you can see, we got hopefully some quite exciting things to talk about. So we'll start with what is mental health rehabilitation. Then we'll touch on the current service provision that we have in place. Then talk a bit about what is it we want to develop in Sussex, and how is it we want to transform services. We'll then hand over to Nicola Iliadis from the Coastal West Sussex, I should say, Enhanced Community Rehabilitation Service, to talk about what they're doing there. And then we'll hand over to Laura Thompson and Becky Marshall, our dual diagnosis. So sorry, I should say actually. So Laura is a dual diagnosis practitioner, and Becky Marshall is the dual diagnosis nurse consultant. We'll then talk a bit about a workshop that we're planning in October, and then finally a bit about how you can get involved. So I think we're starting with you, Emily, aren't we?
Yes, yeah, thanks, Stina. So I'm just going to do a bit of background information, really, starting with what is mental health rehabilitation. So it's been described as a whole system approach to recovery from mental ill health, which maximizes an individual's quality of life and social inclusion by encouraging their skills, promoting independence and autonomy in order to give them hope for the future, and the hope that this leads to successful community living through appropriate support. So that is how we define mental health rehab. And if we go on to the next slide, this is what NICE says about who should be offered a rehabilitation service. So it should be for people with complex psychosis and related severe mental health conditions, where there are treatment-resistant symptoms and functional impairments that affect how a person is able to live day to day and how they are able to participate socially. So this group of people will often be people who've had recurrent admissions in hospital or sometimes extended stays in hospital. And they may be people who are in 24-hour staffed accommodation and their placements are breaking down or risk of breaking down. So next slide, please. So NICE also sets out principles for mental health rehabilitation. So it says that these should be recovery orientated services. They should offer person-centered care and involve collaborative working and shared decision making, both with service users and their carers and families. And there is a recognition that not everybody who goes through the rehab pathway will regain the same level of functioning that they had before their illness. So there will be a proportion of people who will have ongoing, relatively high support needs, and those will sort of need to be met in the community following rehab. So yeah, just in terms of what we have already in Sussex, we have a high dependency rehab unit in Horsham, which is 78 Crawley Road. They have 24 beds there. It's a mixed gender environment, and it's available to people from across Sussex. So it's high dependency in that it offers a higher intensity of intervention, more enhanced intervention. It's for people whose symptoms are still not stabilized and they may still have kind of ongoing risks and problematic behaviors associated with their psychosis. And that's in contrast to the other units, which are community inpatient rehab, which are less hospital based and a slightly lower level of support, but also slightly more capacity for engagement within the community. So it's a way to sort of move people on from a hospital environment to more community living. So we have Amberstone in East Sussex, which has 28 beds, Connolly House in Chichester, Shepherd House in Worthing, and Rutland has just a male only 10-bedded unit. Sorry, in Brighton, that's Rutland Gardens. So in addition to the rehab beds, we also have community rehab teams in each of those areas of West Sussex, Brighton and Hove and East Sussex. The West Sussex team is newly formed, as and Nicola's going to talk a bit more about that shortly, but currently it only serves the coastal part of West Sussex, so we do still unfortunately have a gap in Northwest Sussex, which we're very aware of and looking at ways that we can get some rehab function within that area without additional funding at this precise moment in time. But yeah, hopefully that may change in the future. So this next bit, Stina's going to talk you through in terms of what we need to develop in Sussex.
Thank you, Emily. So so we've now heard so what is community rehabilitation and what's the sort of provision, what do we have in place at the moment? So just want to talk a bit about, so what is it we want to develop in Sussex, and then a bit about what is it that NHS England asks us to do, and you'll kind of recognise the how that sort of fits as it were. Well, hopefully. So starting with, so certainly what we want to do is we want to remodel our mental health rehabilitation care service to include strong multidisciplinary approach and making sure and actually improving access to psychology and occupational therapy. We want to make sure that services are working in a much more integrated way, so not in a silo, as it were, and are very much as the service is accessible and it's included in integrated model planning with system partners. And it's probably helpful when we talk about system partners. So who is that? So that's the local authority, it's housing, it's third sector, it's also experts by experience, so people who use the services and their families. Equitable offer across Sussex, I think that's really important, as Emily said. So at the moment, for instance, in West Sussex, we have a service in coastal West Sussex only, but we haven't got provision in North West Sussex. So that's really important that we're able to meet that in the future, or expand that in the future. Meeting local needs, I think what we need to understand is that although, of course, Sussex, there'll be a lot of commonality across that very large patch, but we'll also have some differences, and it's important that that's something that's incorporated into any plan. So that could be any marginalised groups that we particularly perhaps see in one area. Consultation and support and supervision and training, this is really important. And that's about, again, not working in a silo, making sure this is connected into other services. That could be acute services, it could be more generic services, and certainly also primary care. So that's out in the GP practices. So there is that support available. Co-production, really, really key. So that's from design to delivery. And very much people with lived experience. So people who actually understand what is it that will work, what is it that they need, what does that need to look like. So really be part of that whole process. Timely access, really, really important that there isn't a focus on perhaps having to fill out very long forms. There is an easy way of accessing that service. It's flexible, and not least it's evidence-based. So we know this is what works. It's actually based on data. Certainly what we want to make sure is that what we offer to our patients is the least restrictive practice and real alternatives to hospital-based care. Supporting staff to accessing continuing professional development. I think that's really important to make sure that our staff is up to date, and of course that they actually enjoy their work and stay with the service. So that's about having those opportunities. Coexisting needs, I think that's really key. So to think about that, of course, community rehabilitation and that need, it doesn't necessarily exist in isolation. Very often people will present with coexisting needs. So it could be substance misuse, it could be lots of other things, it could be neurodevelopmental disorders, but that's important that we think about that. What does that sort of fuller offer look like? And finally, to make sure that we embed a compassionate, trauma-informed ethos. So that could, for example, be that there isn't a need to repeat your story. And again, it's made accessible, it's made easy. So moving on to the next slide, please. So what we just wanted to share with you. So this is just I suppose understanding the NHSE, so NHS England, the criteria for transformed services. So for the three, what we call the dedicated pathways, so this is eating disorders, personality disorders, and rehabilitation. So of course, today we're just focusing on rehabilitation. So what you'll see over on the right-hand side, so that's 2 areas, that's across all those 3 areas, and that's improving access to psychological therapies, and it's co-production. And if we just move on to the next slide, what we've pulled out is what's the specific criteria in relation to community rehabilitation. So what you'll notice is that this is very much in line with what is it we want to develop. So we want to address restrictive inpatient settings, make sure that people are cared for much closer to home and in a way that's least restrictive. Making sure that services are set up in an integrated way, working with the core community mental health team. So this is back to not working in silos. And finally, and really important, is the strong MDT approach, to make sure that what's delivered is meaningful and therapeutic in interventions, and there's access to. So, for instance, we mentioned the psychology, we mentioned occupational as well. So it's those sorts of things that we're thinking about. So I thought it'd be helpful just to clarify that for you. So I think I might be handing over to Nicola.
Hello, yes. So yes, my name's Nicola Eliadis. I'm the team leader for the Ada, Arran and Worthing Hub for the Coastal West Sussex Community Rehabilitation Team, which is possibly the longest title I've ever had. So the Enhanced Community Rehabilitation Team in Coastal West Sussex launched in September 2022. So we've been live and operational for just over a year. And we're delivered across 2 hubs, Ada, Arran and Worthing based here in Worthing, and the Western Hub based out from the B down in Bognor Regis. We are a 7-day service, including Saturdays, Sundays and bank holidays. The only day we don't offer a service is Christmas Day, and our core hours are 9 to 5. But we do have built-in flexibility for extended early morning or evening hours, and there is flexibility between the hours of 8 and 8 if there's an assessed need, for example, people that may be in employment and need contact from the team outside of those hours, and that will be agreed locally within the teams. Next slide, thank you. So in terms of recruitment into the team, so we were kind of developed from existing assertive outreach teams. So there was already a sort of core staff group. So we've recruited to an additional 26 roles across both of the hubs, and looked at increasing the range of disciplines that we have within the services in order to develop and deliver an enhanced therapeutic programme. So we have incorporated into the teams now an increased number of occupational therapists, the dual diagnosis workers, dedicated family intervention and carer support workers, employment specialists and housing specialists, alongside the existing roles that we already had of nursing, social work, peer support work and nursing associates. And there's work ongoing at the moment to look at contracting voluntary and community and social enterprise support workers to work within our service to further develop those links within the local communities. So in terms of how we've been working since the launch, so across both hubs, we've had 80 referrals into the service, and from those 80 referrals, 32 have been accepted onto our long-term pathway. 11 referrals have been accepted onto our short-term pathway, which is working alongside existing secondary mental health services to provide a short-term up to 16-week intervention to support people alongside their existing teams. And we've developed interface meetings with the local assessment and treatment services and the rehab and acute wards to look at increasing the number of referrals that we're able to receive into the service. And in terms of looking forward and what's next, so looking to further develop and promote our short-term pathway for people that wouldn't need a long-term rehab intervention, but may have 3 or 4 very specific rehabilitation goals that would enable them to improve quality of life and support in the community. We are having quarterly CPD days, next one due in December, which incorporates a variety of external and internal training and development opportunities for the team to ensure that we are remaining up to date with all of our training. We're continuing to work on bringing the VCSE workers into the teams, and really excited and looking forward to that happening and really being able to expand that area of what we're doing. We're also looking to further support and develop the supported tenancies pilot the programme that is taking place within West Sussex and across the trust at the moment. So looking at how we can work with housing partners to provide short to medium term tenancies to look at supporting people to develop further independence. And we're also looking to establish a sort of mini rehab hub to improve the seamless rehabilitation pathways. So to look at reducing the number of steps that people need to go through in order to be able to access the services in the community.
Thanks, Nicola. And I'll hand over to Laura and Becky now for the dual diagnosis part of the presentation.
Hi there, I'm Becky Marshall. I'm the dual diagnosis nurse consultant for Sussex Partnership Trust, and I'm just going to give a very brief overview of the Trust's dual diagnosis strategy. So it might be useful as a starting point just to clarify what dual diagnosis means. Other ways of referring to it are co-occurring substance use and mental health conditions. So yeah, it's someone who's accessing services who has a mental illness alongside a substance use issue. The reason that the strategy was developed a couple of years ago was in response to sort of national drives from places like NICE, from NHS England, from Public Health England, and from Dame Carol Black's review as well, looking at how services are adapted to meet the needs of people with co-occurring conditions. What we know is that somewhere between, this according to research, 30 to 50% of people accessing mental health secondary care will also have a substance use issue. So it's very widespread. And although obviously we have substance use services locally, with that proportion of people accessing mental health, it's really important that we're able to work alongside and address those needs and understand them. So what we know is that people who have co-occurring conditions have a range of worse outcomes. So higher rates of suicide, higher rates of accidental death, and early death due to physical health complications. So there's a lot that needs addressing. So the strategy primary objective was to employ some senior mental health staff in Band 7 positions across the Trust. We have people employed based within assessment and treatment services who have a remit across adult care, such as urgent care, wards, older people's mental health. And we also have some Band 7 clinicians based within rehab services. So there's the roles are 50% clinical work and 50% service development. So we're looking at not only having input with clients, but also how services, the processes and systems are developed to meet the needs of this client group. So I'm going to hand over to Laura to tell you a bit more about how that works in practice.
Hi, yeah, my name is Laura Thompson. I'm a dual diagnosis practitioner working across Brighton and Hove rehab services. Sorry, could we just go back a few slides? Yeah, thanks. So my post is a full-time post, and I'm split across 3 teams. So locally, services, I suppose, are still configured slightly differently. So in Brighton and Hove, we still have an assertive outreach team and a community rehab team. So I work across both of those. And I also input into Rutland Gardens, which was mentioned earlier, the 10-bed male rehab ward. So as Becky said, this is my role is a Band 7 clinical leadership role, and the work that I'm doing very much sort of implements the co-occurring condition strategy that we have. And as a group, we've developed an action plan thinking about areas of practice that we want to kind of focus on and improve. So that's what the role is, really. It's implementing that. So if we could just go on to the next slide, and I'll talk a little bit about some of the things that I'm doing in practice. So as the Band 7 role, we're not in the rehab services, we're not, well, any of the services anymore. We're not lead practitioners, so we're co-working with lead practitioners. And I suppose the idea of that is to kind of skill up the existing workforce, and it not be about sort of specialists coming in to deliver interventions, but it's about supporting people and working with people with a co-occurring condition. So I will offer, as well as the kind of longer term co-working, one-off reviews to people that would like me to come along and see somebody to give some advice. General kind of informal consultation in the office, can be a part of sort of assessments. So with the rehab team, we're doing kind of quite extended assessments for the long-term clients, so getting involved with those, as well as assessments for people coming into Rutland. Training for staff, so we've got an existing training package, and we're sort of meeting as a group to think about the needs of staff and putting together new training packages. So delivering training is part of the role. Contributing to patients' risk assessments and care plans. So again, the idea of suppose is not really doing, it's working alongside the lead practitioner to help think about some of those issues when somebody's using substances, and what some of the risks might be and what interventions might be suitable for somebody dependent on where they're at in regards to, you know, readiness to change their substance use. Attending complex case and risk panels for the clients that we work with. The role is we're very much trying to encourage joint working with local drug and alcohol services, so CGL in this case, where possible, kind of, you know, having regular reviews, professionals meetings, care planning, making sure that each other are aware of what we're doing, what we're treating. Promoting the importance of mutual aid support, so organisations such as Alcoholics Anonymous, Narcotics Anonymous, Cocaine Anonymous, recognising the kind of importance of these in people's recovery, and getting information out there for people that may not have heard of these services before. So I attend weekly team meetings, so I alternate between the AOT and the rehab team meetings on a Wednesday. I'm at Millview today, which is where the community rehab team is based. Sitting in referrals meetings to make sure that you know, we're not excluding anybody with substance use, and thinking about how we can sort of remove some of those barriers perhaps that are stopping people from coming in and being able to access our services meaningfully. Attending reflective practice, formulation meetings, as well as sitting in leadership meetings. So I in-reach to Rutland Gardens on a Tuesday afternoon. I call it a dual diagnosis drop-in, and that's for both patients and staff. So patients to feel able to come and have a chat, go out for a coffee, if they're ready to start thinking about the substance use, or supporting staff, I suppose, that feel perhaps quite stuck with a patient, thinking about people that are very pre-contemplative about changing their use, and how that can affect the culture and the unit, what it's like when there's drug use on the unit. It's very much about sort of supporting staff as well as patients and trying to improve improve service delivery. So yeah, as I said, very much about improving the service delivery and outcomes for people with a dual diagnosis. Next slide, please. So I've put together two case studies, one from the Assertive Outreach team and one from Rutland Gardens, because I suppose the work is quite different. But just wanted to illustrate with two case studies some of the obstacles and challenges that we faced with this client group, but then also some of the outcomes that my intervention, working alongside with people, I think has made. So first person I introduce you to is David. He's a 35-year-old man with a diagnosis of schizoaffective disorder, ADHD, autism, and polysubstance use. So there we go. We've got kind of the complex psychosis, neurodiversity, as well as substance use. So some of the challenges with this case was that there was very poor engagement with AOT, as well as the drug service. There's very difficult family dynamics, lots of contact with the team, staff burnout. I think people that, he'd had a frequent change of lead practitioner, which again, for somebody with neurodiverse issues had been quite difficult. I think the kind of chopping and changing and ending of those relationships without it always being carefully thought through. There were some prescribing issues. So this particular patient was on a lot of prescribed medication, a lot of it being sedating medications, which in combination with his substance use made this man quite risky of accidental overdose and potential death. And there was quite poor communication between the drug service and the mental health team. So by kind of joint working with the LP, I suppose the idea being to kind of, support the team, reduce staff burnout, work with the practitioners to kind of support them understand some of his needs around his substance use. I kind of pushed for professionals meetings, getting the patient and his family together, along with the AOT staff and CGL, so that we could think about his medication, which was a big thing for him. And we put together a kind of plan, a reduction plan in terms of his drinking and his benzodiazepine use. We got input from the specialists within CGL, so the dependence forming medication team. This chap got on board and very much supported us with a kind of a plan to support him reduce without him feeling too anxious about it, and being able to kind of stop when he's feeling that it's going too fast. And continued working, I suppose, with everybody to try to prevent this man going back into hospital, somebody that has had many admissions in the past. So that's David. We'll move on to the next one, which is my case study from Rutland Gardens. Introduce you to Pete. He's a 49-year-old man with a diagnosis of paranoid schizophrenia. He's alcohol dependent and he's got a long history of polysubstance use. So some of the challenges with Pete, he was very much underreporting his drinking. So there was a 2-can rule in place when he came to Rutland Gardens, which had come from a previous ward, which was in place to try to manage his drinking. But I think what was going on was there was quite a bit of disagreement about whether this man was actually dependent or not. He wasn't always sort of a heavy drinker, but there was a clear sort of psychological dependence and probable physical dependence, given the indicators were all there. He was going out in the middle of the night, up early in the morning. There was quite a lot of irritability when he didn't have a drink. Some of the staff had quite negative attitudes, and I don't think that was all towards him, but it was also about just how we were generally managing this man, and sort of how that impacted on the other patients too. This chap has clearly had very poor, he was in for poor physical health, and he refused a lot of the kind of necessary monitoring and things like that. So we didn't always really know how bad his physical health was, but it was clear his diet was bad. He wasn't eating very much, didn't really know what was going on. And there was a lot of this information was lacking in the risk assessment and care plan on the ward. So one of the things I did with this case is I took it to our monthly dual diagnosis reflective practice, which we all get together, bring cases, talk about some of the challenges and ways that we can, ways we can make positive changes. Training for staff, both sort of the kind of more informal, I suppose, sort of training that can happen when we're in conversation, as well as the sort of formal training. Deliver some drug and alcohol assessment training there, and we've got others lined up to deliver. Took away the 2-can rule because I think it was recognised eventually that with an alcohol dependent patient this wasn't appropriate, and he just wasn't coming forward with how much he was drinking because he thought that he was going to be sort of punished after that. So thinking about restrictive practices that sometimes can just sort of follow patients when they move. The doctor's now prescribing this man thiamine, vitamin B1, given the kind of reduced levels with how much he's been drinking and poor diet, etc. And diazepam as well, early morning, so that it's sort of try and delay when he goes out for his first drink. This particular patient is a little bit more open now about his use. No miracles there, but he talks to us now when he's feeling like going out in the middle of the night, so we can help sort of think about his safety a bit more and his health. And got together and done a sort of updated the risk assessment and care plan. That's the end of my talk.
Thank you, Laura. So I think that's over to me. Yes, been really good just to hear about both both about the work in coastal West Sussex and also the dual diagnosis work. So wanted to mention to you, so what we're planning at the moment is a workshop that we'll do in October. And really what that is, we come to the stage where we want to, lots of good work has happened, and what we want to do is really bring back together, come back round together, if you like, all that work and really be clear about, so what are the next steps and what does that need to look like. So the aim of the workshop will be to establish the principles and priorities to deliver the transformation of community rehabilitation services in Sussex. So starting with understanding the background and context, and of course, so where are we at the moment? So what's the progress that's been made so far? really important. What we want to do is to reach a shared understanding of what are those agreed principles for a future model, and how would that actually unpin the kind of transformation and that transformational model that we're describing. And then finally, to identify the priorities for that future model. I think we're quite clear about we can't necessarily do everything at once. So that's something to think about, perhaps what's the different sort of phases, if you like, that we need to go through. And what is it that's needed to design and deliver these both at place and system level? And when we talk about place, so that's the three different places. So East Sussex, Brighton and West Sussex, and system that refers to Pan Sussex. And I think I'm handing over to Emily.
Yeah, just for the final slide of this presentation. So just in terms of how you could get involved if you're interested in this area of work. So we have the Sussex-wide steering group that Stina and I chair, but we also have local groups in each of the places that are made up of multi-professional groups, different agencies involved with people on the rehab pathway, but also people with lived experience and local commissioners. So for each of those areas, there's some key contacts that you can get in touch with if you'd like to know more and to get more involved. So it's Sophia Iverson and Pritha Taylor for Brighton, Glenn McCready for East Sussex, and Gemma Dora and Martin Pennell for West Sussex. So they would all be happy to hear from you if you'd like to know more and get more involved. And I'll now hand back to Megan. Thank you.
Thank you all. That was absolutely brilliant and very informative. I hope that everyone has enjoyed the presentation today. Just before we come on to our Q&A, just a reminder about the next webinar on the 18th of October. That will be looking at developments so far in developing a new integrated neighbourhood model for mental health teams. So I'll send around the links so you can register for that if you haven't already. But now we're going to get into the Q&A. So I've been keeping an eye on the Q&A box and there haven't been any questions yet. So if you have got any questions that you'd like to put to any of our presenters today, please do put them in now, or alternatively, feel free to raise your hand and you can ask directly if you would prefer. Simon.
I'll just unmute. Yeah, hi there.
Hello.
Yeah, my name's Simon Crane. I'm a speech and language therapist with the SAM team, and I just want it was more of a point of kind of. It was kind of good news point and also a point of information just about the MDTs within the community rehab services. We're actually recruiting 3 new band 7s to speech and language therapists to work within the inpatient rehab units and also into the community mental health pathway as well. So we're just about to go live on that recruitment. So I just wanted to throw that into the pot as an expansion of that MDT that wasn't mentioned earlier. So watch this space, as they say. But thanks, that was it really.
Thanks, Simon. I was thinking about you during the dual diagnosis presentation and wondering if there's things that we could sort of learn from what's worked there in terms of starting off new roles and how we kind of link in with the existing teams and things. So yeah, I thought that's all very
absolutely,
relevant.
Emily. Yeah, I think there's a lot to think about there. Yeah, thanks.
That's brilliant. Thank you, Simon. Okay, we've got a question from John. What practices can be put in place to ensure that teams aren't working in those silos, as we spoke about in the presentation? And what does that, really look like going forward?
Yeah, we're mapping at the moment kind of like the pathways that exist within rehab services, kind of both within what's offered in the service, but we're also starting to think about those interfaces and the sort of broader pathway. And I think Nicola mentioned there are sort of kind of things that they're starting to trial in terms of sort of regular meetings between the different parts of the system, maybe even having like a sort of kind of a hub approach where people come together regularly to talk about those sort of interfaces. So I think that's definitely a part of it. Yeah, and I think it's difficult if people are used to working a certain way, and obviously people need to be clear on what their role is and how that differs from the other teams and things. But I think, yeah, there's also needs to be some flexibility and some communication between the teams so that flow can happen, you know, and people don't just kind of focus on their bit of the puzzle, really. I don't know if anybody else wants to add anything to that. I can see Nicola nodding.
No, I agree, and I think it is very much about just making sure that we continue to look outwards as well, and to, you know, look at what other opportunities there are for people, except that while we provide a very robust and comprehensive service, we aren't the be all and end all, and we won't be able to provide everything for everybody. So about really looking at what other opportunities there are and what we can support other people to link into in the wider community as well, and really looking for those sustainable long-term approaches outside of the statutory services. I think it's really important.
Yeah, I think that's right. And then just adding to that, I think one of the things that made me think about, I think the reality is we haven't got all the answers. What we know is that, as has been described, you know, there's some of that kind of interface that we can you know, change. We can, you know, trial it, see does it work, doesn't it, and sort of implement it accordingly. And of course, there's also, you know, we see some best practice up and down the country. Some of that we can translate to Sussex, some of it not necessarily, because that's of course the challenge that, you know, we're currently set up the way we are. So that's some of that we're sort of grappling with, and I think it's you know, there's something quite important as well about that sort of cultural change. And I think, Nicola, you mentioned that about kind of the staff who's perhaps been used to working in this kind of particular way for quite a long period of time. So it's something that needs real quite careful planning and thinking about and implementation. And really that staff teams are supported to embed that change, because it's not easy, but at the end of the day, it is something about, you know, how can we make sure there is a better offer and a much more integrated offer.
Thank you all, and hopefully that responds to your question, John. I don't know if anyone else has any other questions. There isn't anything in the Q&A box that we haven't answered yet, but feel free to put any other questions in there or raise your hand. We've got another couple of minutes.
I was just actually going to ask a question of Nicola. Sorry, I should have asked you when I saw your slides earlier, but I forgot. But in terms of, you had quite a high sort of referral rate in comparison to people you accepted. And I wondered, is that because people were sort of seeing you as something more or the answer to everything rather than sort of for the specific function that you're set up for? Or was there something else about that sort of data?
I think quite a lot of the early referrals that we had were referrals that were people that didn't meet the referral criteria in terms of either diagnosis, or people that were referred and then went into crisis, and so were either admitted to inpatient units, and so that wasn't appropriate, or sometimes people that were referred that actually weren't within our catchment area. I think people were hopeful that we were West Sussex wide, and unfortunately we weren't. But yeah, so it was a variety of reasons, and quite a lot of the people that were referred that weren't accepted we managed to sort of either give some advice and support, or sort of redirect to other services.
Okay, thank you.
And I think just adding to that, and Nicola, you correct me if I'm wrong, but I think one of the issues as well was that there was perhaps a bit of confusion about what the service was and indeed what it wasn't. So I know you've done a lot of work engaging with other kind of services and making those links to make sure that really that was clear, if you like. And you know, you'll kind of continue to do that and make sure, you know, also as things change and as the pathway sort of has developed to make sure that everybody's really up to date.
Thank you. And we've got one last question, and we can squeeze this one in if people are happy to stay. And the question is relates to a family member, and there was some difficulty in accessing psychological therapy for that person, and the question is, you know, what would have caused those difficulties? Is it due to kind of staffing issues, or is there kind of a shortage in certain kind of skills within those teams? This particular person wasn't able to access NHS talking therapies due to a previous diagnosis of schizophrenia. And they've also said that the Shepherd House team were fantastic, by the way. So there's also a really nice compliment in there. But yeah, so what can cause those challenges in accessing psychological therapies for people who have got a diagnosis?
I think definitely kind of recruitment and gaps in recruitment is an issue. I know there's areas currently where we haven't got a psychologist recruited. I think over in the Chichester Bognor region, that's a gap at the moment, and in Connolly House. So yeah, that certainly is an issue. That psychologists do tend to be part-time, so sometimes it might be there is somebody in post, but they can't see everybody on the whole caseload, so that can sometimes be an issue as well. But yeah, but I think those are the main reasons. I mean, ideally everybody in the rehab services should be offered CBT for psychosis, and should be offered family interventions as well if there's family members regularly involved. But yeah, I think we know we're probably not quite hitting that, and sometimes it's maybe people aren't always recording what they are doing. I think, having spoken to the psychologist, so they might have had an informal conversation, but they haven't logged it as we have offered psychological intervention. So I think there's a recording kind of issue as well. But I think certainly there are gaps where we don't have as much coverage of psychological therapists or psychologists as we would like. But we are looking at that data and trying to improve it. And there's there's sort of short-term CBT interventions for psychosis that are becoming more easily accessible, and people can train in those who perhaps aren't always fully qualified psychologists and therapists, but could be sort of assistant psychologists. So there's ways we can sort of bring in different roles as well where there are gaps. But yeah, we are aware of that and wanting to improve on how many people we get to offer it to and how many people get to benefit from those therapies, definitely.
Thank you, Emily. I'm very aware of time, and a couple of people have had to leave us already as we have slightly run over, but I think it was definitely worth staying on just to be able to get in a couple more questions. But I'd just like to thank all of our presenters today for fantastic session, which hopefully everyone's found really informative, and thank you all for attending and for your contributions and your questions. As I say, I'll send around the slides and some more information about upcoming webinars, so do give that a look, and obviously share the recording of the webinar with any colleagues or family members, friends that you think would be interested in this work. And yes, just thank you again for joining us today, and I hope you have a very good afternoon. Thank you so much.